Yes, sir. We are ready for roll call. Dr. Drake? Dr. Drake? Dr. Gotcher?
I think Diana is still muted, but maybe she unmuted. She's here. I'm here.
Okay. Dr. Hurd?
Here.
Mayor Jacobs?
Here.
Dr. O'Brien?
I'm here.
Thank you. Ms. Roma?
Here.
Dr. Shamia?
Here.
Dr. Sousa?
Here.
Ms. Wagner?
Present.
And Dr. Buchanan?
Here.
Thank you. Folks, thank you. We have a quorum.
Thank you, Norda. At the outset, I want to tell everyone that over the last few days, I've been having a little bit of trouble with the Wi-Fi at the medical center. And when we were doing our resident applications, we had a lot of dropouts. And so if that happens, please be patient or continue the meeting, but it may happen. I hope it doesn't. I haven't detected it so far this afternoon. The next order of business are our public forum, and Dr. Buchanan or Narda, can you all give me a hand with we start that portion of the program?
Kelsey, I believe, will be helping with that.
Yeah, this is Kelsey Wilson, and I will assist in reading out the names for public forum when that time comes.
It's now.
It's now, okay. So first up, we have for public forum, we have Kevin Hill. Kevin Hill, if you are on, you have 3 minutes, and if you can please start out by saying your name and your address as well.
Oh, Danielle's saying she doesn't think he's in.
Okay, it doesn't appear that Kevin Hill is here. So we'll move to the next person, which is Sherry Garrett. If you are on, Ms. Garrett, you have 3 minutes. If you can begin by saying your name and also your address.
My name is Sherry Garrett. I'm at 7900 Sharp Road, Powell, Tennessee 37849. The existence of the Knox County Board of Health is unconstitutional. This body falls under the executive branch of the Knox County government and therefore has no constitutional authority to make law. The people of Knox County have a right to be represented, and yet there is no representation on this board as there are no elected members with the exception of Mayor Jacobs. Tennessee Constitution Article 1, Section 1 states that all power is inherent in the people and all free governments are founded on their authority and instituted for their peace, safety, and happiness for the advancement of those ends that they have at all times. An unalienable and indefeasible right to alter, reform, or abolish the government in such manner as they may think proper. This Board of Health has established mandates that are harmful to my health and to many others. Many in this county have medical and or psychological exemptions to wearing masks, yet we have been turned away from businesses, have been discriminated against, threatened, and some have been physically assaulted. Yet this Board of Health's response is, that's unfortunate. Now let's get to tonight's social gatherings limitation. The First Amendment to the United States Constitution states, Congress shall make no law respecting an establishment of religion or prohibiting the free exercise thereof or abridging the freedom of speech or of the press or of the right to people to peaceably assemble and to petition the government for a redress of grievances. Therefore, any limitation on gathering size is unconstitutional and therefore is null. Now, finally, we have asked for a forum where we can ask questions and get answers. Some of us have submitted questions, yet they have been ignored. We demand a back and forth narrative where we can ask questions, get answers, and have the ability to cross-examine those answers, either with Dr. Buchanan and or members of this board. You cannot or will not schedule one. We will schedule it and send an invitation. Thank you for your time.
All right, next up for public forum, we have Anastasia Juneau. If you can start out by saying your name and your address, you have 3 minutes. All right, if Anastasia Juneau, if you are on the call, I believe you were let in. All right, last call for Anastasia Juneau. All right, next up we have Vernon Henry. You may please start out by saying your name and your address. All right, not seeing Vernon Henry here, so we'll move on to Christine Cruz.
I am here.
Okay, all right. Well, then go ahead and you can say your name and your address as well, sir.
You can't see me. I don't know what's wrong with the camera system, but this is Vernon Henry, Knoxville, Tennessee, 37922. I hope to get the attention of the board members who seem to be doing other things and not paying attention. Would love to have your attention momentarily. You're a non-elected board given the powers to make rule and regulation without the responsibility. Yet your group has single-handedly caused the destruction of many small businesses, which I have brought to the attention of the city council. These businesses will never return. You've literally ruined the financial well-being of many families. Yet you are still drawing an income. The primary controlling institution of the UT5 has netted over $80 million in profit over the last 3 months. This is just unfathomable. You're continuously marketing of the harbinger of death, a virus that has a recovery rate of 99.97, has been an impressive use of the media. It's so impressive, you've got people who are wearing a mask while driving in their cars by themselves. They're wearing a mask while walking out in the woods. I have seen small children and infants wearing a mask because their parents and you have actually pushed this narrative. You've caused more damage than you've done good. I would like to recommend to those who have suffered under your mandates to reach out to you directly, call you, visit you, invite themselves to lunch or dinner. Let them know what you have actually done to them. This mandate should not be in place. This is not necessarily about wearing a mask. It is the powers that you are exercising to dictate whether as a healthy individual, I should wear a mask. If you want to wear a mask, I think that's great. If it makes you feel comfortable, I think that's fantastic. But I do not need to be dictated by wearing a mask or with whom I'm going to spend time with or the number of people I'm going to spend time with. I have the ability to know the difference. I am calling upon the individuals of Knox County to openly defy you. Your basically should be a recommendation, not an edict. We have asked you for an open forum to directly respond to your actions, yet you have continuously pushed us off and pushed us away. We deserve answers. We require answers. Because at the end of the day, as I said, you are a non-elected board. You should be an advisory board and advisory board only. That is my time.
All right, next up, I believe Anastasia Juneau just joined the meeting. So Anastasia, if you are on, you may have the floor. You have 3 minutes. If you can begin by stating your name and your address. All right, not hearing anything from Ms. Juneau, so we'll move on to Christine Cruz. Christine Cruz, are you on?
I'm here.
All right, you have 3 minutes. Please begin by stating your name and your address.
My name is Christine Cruz and my zip code is 37919. My gate was vandalized, so I will not be giving that out again. The definition of insanity is repeating the same behavior over and over and expecting a different end result. There is no provision in the U.S. Constitution to suspend the civil liberties of any American citizen under any circumstance, including a pandemic, epidemic, or natural disaster. The founding fathers did have personal experience with disease and disasters, so it is not like it was overlooked. It was deliberate. The existence of the Knox County Board of Health is a direct violation of our civil liberties as American citizens due to the fact that it is a group of unelected and appointed people who impose mandates, which are not laws, that restrict the rights of free citizens to conduct business or worship freely under the threat of prosecution, financial ruin. When in history has anyone had the power to contain a virus? Prior lockdowns, curfews, and mandates have all proven this fact to be true. It cannot be done. To double down on this known failed method going into the Christmas season is an egregious attempt to bankrupt small businesses and force people into government dependence. Doctors have been successfully treating patients without hospitalization and very few deaths, including those who are immunocompromised and in the high-risk populations with therapeutics and treatments to boost the immune system. Yet they are being discredited, fired, and threatened by government bureaucrats who have a different agenda. Many people choose to get second opinions regarding their medical treatments. Science is never settled. If that were so, we would still be treating deadly diseases by bleeding patients, and many cures would have never been discovered. I am sure we will hear a lot about surges in positive COVID cases over the Thanksgiving holiday because people chose to ignore the sage advice of Dr. O'Brien to just stay home for 4 days. The reality is that the people who count the cases were on vacation, so there's a lag in reporting, which looks like a surge when in fact it is due to the Thanksgiving holiday. So for Dr. O'Brien to think he can dictate what any free citizen of this county or country must do according to his will, while Dr. Drake is giggling from her Arizona location celebrating her Thanksgiving holiday, is appalling. If it weren't so tragic to see the effects on families' lives and businesses during the Christmas season, it might be an amusing SNL skit, but there's nothing funny about tyranny. Thank you very much.
All right, next up, we have Richard Cunningham. If you are on, please begin by stating your name and your address, and you have 3 minutes.
Thank you. Richard Cunningham, 1836 Bombay Lane, Knoxville, Tennessee, 37932. I want to thank you for the opportunity to address the board. I'd first like to thank Mayor Jacobs, who always responds and is a voice of reason. I also would like to thank Mrs. Roma, who is the only other member of the board that responds to my various emails and discussion. We may disagree, but at least she takes the time to respond. But most of all, I'd like to thank Randy Burleson for his address to you last week. Without his input, I'm afraid you would have devastated the hospitality industry even worse than you already have. Many locally owned restaurants are suffering from both the pandemic and the board's response. Please do not hurt them further. We will likely hear later in this meeting regarding benchmarks. One such red light will be testing turnaround. We have a local lab with same-day turnaround that for some reason we don't use. There's no excuse for sending out testing with slow turnaround when you have a local lab that is same day. So this red light is completely bogus and unnecessary. Hospitals are busy. It's that time of year. Having worked in hospitals for 25 plus years, I can tell you they're busy this time of year. They're busy this time of year pre-COVID, during COVID, and they will be post-COVID. It's not new. Which brings me to another point, hospital staffing. As of today, 2,247 healthy Knox County students are in quarantine. Who do you think has to stay home to watch these kids? If you answered healthcare workers, you'd be correct. Dr. Jay Bhattacharya, to whom I've referred all of you through various emails, is an expert from Stanford, has an excellent paper on the futility of contact tracing, especially at this point in the pandemic. It's simply a waste of time and damaging. If you would simply stop this insanity, it would go a long way to alleviate hospital staffing. But lastly, I want to talk about credibility. We've seen national leaders such as Speaker Pelosi get her hair done at a supposed to be closed salon with no mask on. California Governor Newsom dines at a fancy French Laundry restaurant against his own orders. The Denver mayor last Wednesday tells us not to travel. Then 30 minutes later, he's seen at Denver International getting on a plane. But it's not just nationally. This board last week admonished us not to travel for Thanksgiving, that we just needed to stay home. If we stay home for 4 days, it would alleviate everything. Yet while you were telling us this, one of your members was in Arizona. We aren't stupid. We notice these things. And if you don't follow your own rules, why should we? 2 vaccines and likely more are on the way. Don't keep enacting mandates just to show you're doing something. Protect the elderly and vulnerable. And for those in the medical field, please remember the very first statement of the Hippocratic Oath that you took. First, do no harm. Thank you very much.
All right, and last call for Kevin Hill or Anastasia Juneau.
Yes, I'm here. I don't know if you can see me.
We cannot see you, but we can hear you. Is this Anastasia?
Oh. Yes, it is.
Okay, Anastasia, if you want to begin, you have 3 minutes. Just please state your name and your address.
My name is Anastasia Juneau, and I live at 10,200 Meadow Ridges Lane, Knoxville, 37922. Yeah, I would like to thank Mayor Jacobs for voting against this mask mandate, and I'd like to thank Sheriff Spangler for refusing to enforce this mask mandate. And I'd like to applaud Dr. Hall and Dr. Smith for their lawsuit against the Knox County Board of Health for the use of this unreliable PCR test. And I would like to also have you listen to, if you can hear him, Carrie Banks Mullis, who is an American biochemist who invented the PCR test. And this is an interview, and it's been edited for a minute, of him during the big HIV scare and how they used the PCR test to diagnose HIV. And the interviewer was asking about its reliability. And Carrie Mullis said, it's reliable, but it can be easily misinterpreted. So I'd like you to listen to what he had to say. Just getting him on right now.
I think misuse PCR is not quite, I don't think you can misuse PCR. The result, the interpretation of it. See, if you can say, if they could find this virus in you at all, and with PCR, if you do it well, you can find almost anything in anybody. It starts making you believe in the sort of Buddhist notion that everything is contained in everything else, right? I mean, because if you can amplify one single molecule up to something that you can really measure, which PCR can do, then there's just very few molecules that you don't have at least one single one of them in your body. Okay, so that could be thought of as a misuse of it, just to claim that it's meaningful. But it allows you to take a very minuscule amount of anything and make it measurable, and then talk about it in meetings and stuff like it is important. See, that's not a misuse. That's just sort of a misinterpretation. PCR is separate from that. It's just a process that's used to make a whole lot of something out of something. That's what it is. But it's not. It doesn't tell you that you're sick, and it doesn't tell you that the thing you ended up with really was going to hurt you or anything like that. That's what it's not.
So even if you believe in HIV, it can't tell the difference between virus particles or active live virus. I mean, there's a lot of questions involved.
Thank you. So that, can you still hear me? Oh.
Yes, we can.
Yes, we can.
Oh, yes. Can you hear me?
Yes, we can.
Ms. Anastasia, or Ms. Juneau, sorry. That's your time, so thank you. I believe that unless Mr. Hill is on, that concludes public forum. Mr. Hill? Okay, Dr. Gocher, that concludes public forum.
thank you, and thanks to our citizens that were on the public forum that took the time and effort to give their opinions. They are appreciated. Thank you. Next item on the agenda is approval of the minutes from the November 10 and November 23rd meetings. Those should have been sent electronically, or you should have a copy of them. At the outset, any questions or any discussion about those minutes from either meeting?
One minor change, Dr. Gocher, in the second set of minutes, there's just a misspelling. Section 5, heading C, social versus SoCal. Something very minor, just to change the spelling. And I'll move that the both sets be accepted.
So we have a motion. Is there a second to that motion?
Dr. O'Brien, which set had the spelling error?
The one from last week, section 5, section C under 5.
Okay, thank you.
The header said SoCal instead of social, that's all.
So we have a motion. Was there a second?
I'll second.
Thank you, Dr. Sousa. Motion and a second. Any other discussion on the approval of the minutes from November 10 and November 23? Hearing none, since we're ready for a vote. So Narda, if you will lead us through a roll call on the approval of minutes, please.
Yes, this is Nora Cappuccilli, and we are taking vote to approve both minutes of November 10th and 23rd. Dr. Drake? Drake?
Yes.
Dr. Gotcher?
Here, approved.
Dr. Hurt?
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
Dr. Buchanan?
Yes.
Passed unanimously. Thank you.
Thank you, Narda. You have approved the minutes. The next item on the agenda is to set the agenda, item 6. So you have before you, either electronically or maybe printed, the agenda. Any questions or concerns about the agenda? If not, we would accept a motion for approval and a second for further discussion.
Dr. Gocher, just want to make sure that you had received my request at the end of my comments that there was some data presented to me that I didn't feel really equipped to be the one to present. And so one of our data analysts, Keith Britt, was invited to present just at the end of my presentation. So it's really not a separate agenda item, but I just wanted to set that expectation, make sure you'd gotten that.
I had gotten the request, Dr. Shamia, and fully in favor of it as part of your talk. Any other discussion on that point from any of the board members?
Do we have to have a separate agenda item for our guest speakers that I see that are present?
Dr. O'Brien, I think within the framework of benchmark presentation and data update that may be able to be incorporated in there.
I just wanted to make sure that having them was included as part of the agenda. That's all. Thank you.
It's certainly, if a member wishes to break that out and have a separate discussion or vote on that, perfectly fine to do so if you'd like.
I do not. I just want to make sure it's just considered as part of the agenda that they are speaking. That's all.
we can always run this by Mr. Sanders and see if there's any legal issue with that. I don't foresee any. Mr. Sanders, if you're on, do you have any comment?
I've spoken with Dr. Shamia about this previously. I don't see any reason to amend your agenda for something that's essentially a subset of his report.
Okay.
I think that we may be referring to some additional guests from the other health systems, I believe is what we're referring to.
All right, well, the same logic. If it falls within something that is already broadly on the agenda, I don't think you need to amend your agenda to include it. If you're bringing up some entirely new agenda item, then yeah, amend your agenda. But if it's just a report from somebody else that on a subject matter that you already have on your agenda, I don't think you need to amend it.
Thank you, Mr. Sanders.
Motion to approve the agenda as is.
Second.
So we have a motion and a second. Any other discussion on the agenda, setting the agenda this evening? If there is no other discussion, we can go ahead with a roll call vote. So Narda, if you will conduct us through that roll call, please.
Yes, sir. This is Narda Capicelli, and we are setting the agenda. Dr. Drake?
Yes.
Dr. Gotcher?
Yes.
Dr. Gotcher? Dr. Hurt?
Yes.
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
Dr. Buchanan?
Yes.
Wonderful. 10-0. We have set the agenda.
Thank you, Narda, and thanks everyone. So the next item on the agenda is Knox County Health Department benchmark presentation by Dr. Buchanan. So Dr. Buchanan, if you would like to proceed with that, please.
Absolutely. Thank you, Dr. Gocher. So first I'll just talk about the local data. Yesterday we hit a new high of 437 new cases of COVID in Knox County. Today we're still quite high at 377 new cases since yesterday, giving us a total of 19,315 cases since March. Additionally, we have 1,106 probable cases. We have 45 of our cases are considered inactive, giving us 2,597 active cases. 609 individuals have been hospitalized at some point in their illness. And currently we have 130 Knox County residents in the hospital. Excuse me. Sadly, we have 7 additional deaths to report today, raising our total to 179. Moving to our first benchmark, sustained reduction or stability new cases for 14 days. Over the past 14 days, we hit a new record high in case volume. There were 5 red flags detected, 3 of which occurred on consecutive days, and 2 yellow flags. We saw an average of 243 new cases per day over the past 7 days, and 208 new cases per day over the past 14 days. Because of these factors, we are representing this benchmark as red. Our second benchmark, community-wide sustained and increased diagnostic testing with consistent or decreased test result reporting turnaround time. There were 4 red flags and 2 yellow flags regarding testing, and there were consecutive days of flags during this time period. However, the total number of tests conducted has increased over recent weeks, which you attribute to folks getting tested before the Thanksgiving holiday. I know our testing increased right before the Thanksgiving holiday. Lab turnaround time saw 7 red flags and 2 yellow flags, all on consecutive days. Turnaround time has increased since the beginning of September and is on average between 5 and 6 days. However, during this time period, it has been slightly higher and closer to 7 days here in Knox County. Because of these factors, we are representing this benchmark as red. And that's actually true across the state. That's not unique to Knox County. Turnaround times have gone up, and part of it's related to, some of it's related to process, some of it's related to volume. Third benchmark, sustained or increased public health capability. The goal remains to initiate investigations for all new cases within 24 hours of notification and initiate close contact investigations within 48 hours of notification. However, due to recent process changes and the volume of cases, the way we represented this benchmark previously is undergoing changes. A traffic light color will be assigned based on KCHD's internal assessment of our current ability. During this time period, the high volume of cases, the longer turnaround time, and challenges with the data reporting system, our assessment of our contact tracing capabilities leading us to represent this as red. We want to remind everyone to take personal responsibility and quarantine themselves at the first sign of exposure. You should not wait to receive a call from us or anyone else in public health to start taking action. Isolate yourself if you have symptoms or if you've been exposed, and start calling those your close contacts to make them aware so they can begin quarantining. Additionally, if you have been tested, regardless of whether or not you have symptoms, you need to quarantine until you get your results. So for our fourth benchmark, healthcare system capabilities remain within current and forecasted surge capacity. During this time period, there were 11 red flags and 2 yellow flags detected for the number of inpatients with COVID-19, of which there were several 3-day trends. Additionally, there were 11 red flags and 2 yellow flags detected for COVID patients in the ICU, some of which occurring on consecutive days. 6 red flags and 1 yellow flag were detected for consecutive days for the number of COVID patients on ventilators. And after speaking with our hospital partners, and I know Dr. Shamil will speak about this some more, they at this time recommend that their benchmark be represented as red. Our fifth benchmark, sustained or decreased related death rate for identified positives or probable cases. We have seen 26 deaths related to COVID over the past 7 days, excuse me, and 36 deaths in the last 14 days. Those are sobering numbers. The information available leads us to represent this benchmark as red. Under our supplemental data section, the first chart shows daily COVID cases per 100,000 population. As of today, our 14-day trend line shows 47 new cases per 100,000, and our 7-day trend line shows 60 new cases per 100,000, well above our metrics for both of those. The second chart shows the percent positivity. The 7-day average for percent positivity here in Knox County is 20.17%. So again, all of those are above our set metrics that we've determined as the board. Happy to answer questions. It takes some time to absorb some of the data. I think the sobering data is really the fatalities that have occurred. Our case numbers are really high, but our fatalities certainly are matching that.
Any questions or discussion for Dr. Buchanan's report? If not, Dr. Buchanan, we thank you for that complete report. Again, very sobering information, but we appreciate your diligence in assembling that and helping us through it. Next item on the agenda is the University of Tennessee Medical Center's Knoxville data update from Dr. Shamia. So Dr. Shamia, if you're ready, we'd like to hear from you.
Great, thank you. And so I'll present my typical information, then address the transition to red and what went through some of that thought process. And then we'll tee up our our guest with that additional data. So when we look at new cases by week and by month, you see the steady rise. You know, there was not really a lot of testing at all that happened over the 4-day Thanksgiving holiday. I know there are people who tested before Thanksgiving, but the fact that that final week dipped in the county and the district really is likely due to just not a lot of people getting tested around the holiday. That makes the most sense, not that that number dipped. And you also see on the right-hand side just what November in the county and in the district, what the magnitude of new cases in November compared to October, it was significantly higher. Next slide, please. So across the region, you see that this is consistent across the state. We've said this now for the last several weeks for all the population centers, quite frankly, for the entire state. Next slide, please. So we focused on this. This is becoming really even more significant in that by far the highest point of cases are being diagnosed in those who are 51 and older. This is important for two reasons. We do think that at this point, symptoms are probably driving more testing than anything else. And we know age is a factor in making persons more likely symptomatic as opposed to asymptomatic carriers. The other is that group is the group that's most likely to be hospitalized. And so this, the fact that we're seeing that appears to be kind of the new normal of what we're seeing in the age demographics of positive tests. Next slide, please. So this was a single day snapshot from December 1st in our hospital. Again, I don't have access to this type of data across the entire region, but this just shows you the age distribution of patients in our hospital on one day. On the left-hand side, that is in the acute care, non-ICU. On the right-hand side is the ICU. So while that you certainly see the highest number in 70 and older, you see several different decades of age represented across the board, just making, emphasizing the point that this does have an age spread in terms of those that it affects to the point that they require hospitalization. Next slide, please. The positivity rate, the point that I would make here is that, again, reporting has been kind of intermittent in terms of how steady it's coming out due to a variety of factors, including just the caseload. And so basically this was switched from the average of the last 7 days positivity rate to the sum of the last 7 days positive test divided by the last 7 days total results. But it's still very consistent. We are higher than 15% positivity rate and still rising. So would imply that we are not in any, as all the data does, that from a public health perspective, that type of positivity rate indicates that we really don't have control of spread and control of the pandemic. Next slide, please. So as far as hospitalizations, I've mentioned over and over that we've transitioned to where looking at daily census as opposed to new hospitalizations is more useful. This is data that comes from TDH, and I think it's becoming even more delayed than it has traditionally been because of the number of, this is generated through contact tracing. And as Dr. Buchanan stated, the contact tracing system is strained. Therefore, this data is coming later and later about new hospitalizations. But still shows a steady amount. Next slide, please. So I think this is really, it needs to be emphasized that we are now through the district at 420, and you see how this most recent spike, which we got to 236, leveled off. And then have just in what I would call a consistent spike that is showing no signs of leveling off. And I think importantly, this has nothing to do with Thanksgiving gatherings. We won't see the effect of the Thanksgiving holiday for a few weeks. So these are all cases that were diagnosed that then led to hospitalizations. And again, the word census here means these are the number of people in hospitals with COVID-19 across those counties on each day. And so this is all activity that happened before Thanksgiving. Next slide, please. So, I've always said that these trend lines, we don't know really exactly, none of us can predict the future, but you see November 8th is pointed out there at 233. And what to me is striking about this is how consistent those last three trend lines are. And what I've said before is that when it's scattering all over the place, this is a very limited utility. But when we start to see week after week trend lines be consistent, it would seem to be a little more reliable, although still we don't know exactly that that's where we're going to stand, where we're going to land. Then next slide for me, and then I'll talk about transition to red. So I do want to mention this as an update. This is directly from the Knox County Health Department's benchmarks that Dr. Buchanan showed. And the format of this has been updated a little bit. It's not that I think that a ton of people are out there looking at this every day, but I've mentioned this in the meeting before that it was important that we, as we move into this next phase, that we make sure that no numbers are misleading. And so the point that I want to make here is that you see on the top is the format before December 2nd, and then below is the format as of today. And so the all hospital beds piece is nearly the same number. There's an addition at the bottom that's adult floor beds, non-ICU. Then the ICU beds below that is almost identical, and the ventilators certainly is very similar to what it's been. I think there's two things to point out here. That all hospital beds has always been every licensed bed in the region, regardless of its purpose. So that 3,000 number, that included neonatal beds, that included beds in Children's Hospital, that included behavioral health beds. And so while that's still there, from a hospital system perspective, it was felt to be important to say, what are the beds that are not ICU beds that would really be appropriate, assuming they're staffed, to take care of patients with COVID-19 or other medical illnesses? And that's that 1,861. So it's not that that has ever changed. That's what it's always been. But it's just that 3,000 number was, it represents, it is true total capacity of all hospital beds, but it's all kinds of different beds. And so that's why in discussions, it was felt that from a hospital system perspective, we wanted to have that additional line added. And certainly all this shows that we're more full than we've been. And so to address the decision to move to, I think you can pull the slides down for a moment. And so to address the decision to move to red, we had that, we have that discussion every Wednesday. We actually have a few representatives from the other systems, which after our guest, I think this would be a natural time to have them chime in. But the types of things that we all look at, we look at the number of patients that are in our emergency department that are having to wait to get a bed upstairs and how long they're having to wait. We look at whether hospitals have had to go on something called critical status or divert status. What that means is that things are so full and so packed that for a period of hours, ambulances preferentially, except for certain diagnoses, go to other hospitals that are doing better than that hospital at that time. We look at our ability to place patients with COVID-19 because, as we've said, we try to put that population together for infection prevention reasons. And so depending on how many of those patients there are, we may be having difficulty placing those particular patients. How long ambulances are having to wait at our facilities. If we have patients who are having surgery and post-operatively, we're having difficulty in a timely manner placing those patients in beds, that goes into that. And then the other thing is we've defined that when we went through our last iteration of trying to make kind of our new data is the idea that red implied that there has been an impact to normal hospital operations. And there's been some change. And I know that the systems have all had conversations about kind of where we're headed next with non-essential procedures. And so that has been a very real conversation this week. And so all those things together and very much have, I mean, if you look at we still have that daily capacity call with the systems. And if you truly look at what the COVID-19 census was on the Tuesday and Wednesday before Thanksgiving, and then what we've had on the Monday and Tuesday after Thanksgiving as a whole community, it has been a very significant increase. And so all of those factors went into play in that decision. And so I think to finish the formal part of this, but I do want to make one other point is that, and I know the other folks will make this too, is that we still want to make it very clear that the hospitals from a infection prevention perspective are probably one of the safest places in the community. I mean, we follow every rule we can possibly follow. And what we don't want to do is at all send a message that sick people who have things other than COVID-19, that we don't want the message for you to think that you shouldn't come to the hospital. You absolutely should come to the hospital. You should come to the emergency departments. We're going to continue to manage this as a team in this community, and we're going to try to be very measured in our response, because we know there's a lot of sick people that don't just have COVID-19. So I do want to introduce Keith Britt, one of our data analysts. He showed me some very high level publicly available mobility data, which I know had started to be discussed in this meeting. But what was striking to me is looking at the Thanksgiving holiday and correlating it with some prior holidays, and then how that mobility data in turn correlated with some of the spikes that we saw. So I'll turn it over to Mr. Britt.
Hi, and I will go ahead and share my screen if that's okay. And I think you all can see that presentation header now. Okay, so yeah, I'm here just to present some mobility data that we regularly look at. We've been looking at some mobility data since about May. We found it pretty important to present it now because there's a mobility data signature that we really haven't seen now, or we've had confidence in now, and we just recently saw it, so we wanted to make you aware of it. So, and somehow my computer isn't letting me change slides. 1 second here. Okay, here we go. Okay, so we're going to show you two different mobility data sets. Both of these are publicly available. You don't need any special permission. You don't need any user account. Anybody can go out there and get these, reproduce what we've done, double check what we've done. And we encourage you to do that. That's part of the scientific method. So please go and explore these data sets yourself. These data sets are very large. In order to make these as reproducible as possible, everything I'll be presenting here, I just put together using a spreadsheet program that is free and available to everybody else. But they're very large, so they may crash that. We've narrowed this down to, we're just only using Knox County data. These data sets contain data for every county in the nation, and the other one contains an entire global picture. None of this data is able to reveal or track individual devices or users. It only counts in aggregates of users with some light classed places isolated, but in no way is this revealing anybody's identity or tracking anybody's movement. So the first data set is from Descartes Labs, and this is what Knox County has looked like since March 1st. the main reason we're showing this is what you may have seen in White House coronavirus task force reports. This is the data set they use. So it was naturally a good place for us to gravitate towards. The orange line is the daily mobility number they calculate, and the green dotted line is a 7-day average. What you can clearly see there is back in March and April, when the local and then the subsequent state safer at home orders were placed and the pandemic was beginning, we definitely see a mobility drop. But ever since around mid-June into July and up till now, we've hovered around that mark of 80. Now 100 is the baseline. 100 is where they would expect us to be mobility wise. So throughout the course of the year, we've stayed below where we were from their baseline, which is a point in January and February that they took an average of. But other than that, this mobility data set doesn't really reveal anything to us. But I will just point out some specific dates on here for you. So we have 5/25, which was Memorial Day, the day before and Independence Day, Labor Day, and then Thanksgiving and the day after Thanksgiving. Again, even pointing those out, there's nothing really unique or any type of signature that jumps out at us. So that I point this data set out only to say that we didn't make much use of it. So moving on to the Google data set, this is from Google Mobility. They don't just look at the county as a whole. They're able to subdivide the county into 6 different sectors. So the 2 main sectors that we pay attention to are workplace and residential. I know this may be a little hard to see now. I am going to zoom in and show those in detail. But those are the 2 we look at in detail, and then retail, recreation, grocery, pharmacy, transit station, and parks. Those can be treated as kind of supplemental. So looking at the workplace mobility, you can kind of see that same curve that we saw back with the Descartes Labs data. You see the beginning of the pandemic. We see actually a dip in mobility there. So here before, when we had 100 as the baseline, here 0 is the baseline. So 0 is where they expected us to be based on pre-pandemic levels. Since the pandemic began, people's workplace mobility is consistently lower. It's just to what magnitude it is lower. And what you might notice is there's some pretty big outliers that jump out there. And so those are individual days. So what individual days are showing very, very low workplace mobility? Well, it's pretty widely expected that their Memorial Day, the day before Independence Day was on a Saturday. So the Friday before, you see people going to work far less, Labor Day, and then Thanksgiving and the day after Thanksgiving. So those are 5 days that really stand out as outliers. But in terms of mitigating the pandemic, just on its own, this doesn't mean much, because we've always encouraged people, if you can work from home, work from home. Don't interact without masks or social distancing with your coworkers. Those would actually seem to be good things, that we're seeing people go to work less. But that would only be associated as a good thing if the alternative is something that is not more likely to spread the virus. So if they're not going to work on those days, are they staying home? So we look at the corresponding days for the residential data set. So we're above the baseline now. So this is people are spending consistently more time at home. Those days we do see some smaller spikes in people staying at home, but it's not to the same magnitude that we see people taking off work. So if people aren't going to work and they're not going home on these days, what are they doing? Well, we do have those 4 other data sets. So transit stations, this does not include airports, but they aren't traveling on those days. Retail and recreation, those are all below baseline. They're not shopping on those days, especially Thanksgiving. Grocery and pharmacy, those all hover pretty close to baseline, but they're not going to grocery stores and pharmacies on those days. Parks, so these are city parks, national parks, just about any outdoor venue with a name that's not privately owned. We do see on Memorial Day and the day before Independence Day some increase. People were staying outside more, which we think probably helped blunt the effects of virus transmission then. We did not see that on Thanksgiving, and we do not have data for that on Labor Day. So in short, they weren't at home, they weren't at work, they aren't at any of these places, any of these categories of places. They're most likely in a social environment that is more likely to increase disease transmission. So, but what does that mean? And can we correlate that to any effects we see in the hospitals? Well, yes, we can. So we saw the beginning of that first surge in our hospital census 26 days after Memorial Day. And then while that surge was happening, we had the Independence Day holiday and the July 3rd increased mobility. So those were stacked on top of each other. Now, why did that surge start 26 days after Memorial Day? Well, we estimated at that time with the number of active cases and just the level of community spread, it took 5 to 6 maybe generations for that spread to catch up to create those hospitalizations. So it could have been younger people passing it on to older people or less vulnerable people passing on to more vulnerable people, but that process took some time to reach the hospitals. Once we peaked and we started that decline, we leveled off, and then we had Labor Day. 19 days after Labor Day, we began to see another spike. Why is that period of time shorter? Why 19 instead of 26? Well, we believe it's just going to take less generations because we were working with a much higher active case base. So more community spread, it just takes a shorter amount of time. It takes a shorter amount of time to hit the hospitals. And then we leveled off, and now we're in this spike again in our current situation. But we don't have a mobility signature to say that really points to why we're in that spike. So if we go back and we look at that workplace, which we see those really clear data signatures, we do notice that we have a data anomaly that lasts a whole work week in mid-October that kind of lines up with the correlates with the spike we're currently in. That was fall break. So it looks like not a lot, but some parents took off fall break to spend with their kids. But that spike starts on November 7th. That could be contributing to it, but it's just not a big enough event that we think it could have caused this spike right now. What we're more inclined to believe is that it has to do with seasonal temperatures. We've been reading research on this since late February into March. In April, we got a really strong sense that this virus responded very strongly to seasonal temperatures, just the way we saw it migrating across the globe. We had some confirmation of that earlier, October, September. The spread nationally has moved north to south. The colder states are getting hit harder and before we are. And the warmer states are really the only ones that are still not completely covered in red. And our current spike does seem to track with that. As our temperatures are dropping, this surge is increasing. So we've looked at the first 3 spikes of mobility, but those last 2 spikes associated with Thanksgiving, they aren't there yet. We have not felt those at all. But in summary, we do have good evidence that the previous 2 surges were triggered by Memorial Day and Independence Day. We saw the same type of signature we saw from those previous holidays on November 26th and 27th, and we have really high confidence that that's going to cause another surge. The current surge we're in we believe is being driven by seasonal temperatures. And I honestly cannot tell you how big the surge we're about to experience is going to be. I don't know how bad it's going to be. I don't know how big it's going to be. All I can say is that it's very likely that we are going to have a surge based on all the observational data we have so far. And I'm happy to take any questions you have, but that's all I have to present.
Thank you for your presentation. Board members, are there any questions or comments for Dr. Brett?
One comment and then I don't have it at my fingertips, so another question too. So when we look at the mobility data and people aren't at work, they don't appear to be equally at home, assuming they're gathering somewhere is kind of a big leap, since we can't see them. So where does that come from?
Excellent question, Doctor. It's not so much a leap. We're not leaping there. We've just not been able to find an alternative scenario. So we've looked at all the other possibilities of what could be happening in those giant mobility shifts. We certainly don't want to assume or say that it's positively that these people are in social gatherings in an environment that would increase virus transmission. We just can't find an alternative for that.
Okay. And then when we talk about seasonality, and I was trying to look it up and I can't remember off the top of my head. I was thinking that Texas was also surging right now, or had been surging, and I would not call them a cooler climate at this point, or actually rarely would I call them a cooler climate. So, I mean, is that consistent from other countries? I just haven't seen that data.
Again, an excellent question. So yes, we are seeing surges in Texas. We're seeing surges in Arizona, California, Florida, climates that are much warmer than ours. And conversely, we're seeing an abatement of the virus in Alaska, which is I used to live in Alaska. It's a much colder climate than ours. But we do have to consider that seasonality and temperatures are not the only factor in virus transmission. Population density, public transportation availability, those are huge factors as well, and as well as policy. So we do see varying policy from state to state, county to county, and certainly country to country.
Thanks.
So concerning Texas, Texas is, from a climate standpoint, a really highly variable state. From Brownsville, which is subtropical, up to the Panhandle, where the altitude is close to what it might be in New Mexico. So there's huge climate swings that occur, for example, between Amarillo and Houston, or Amarillo and Brownsville. Is there any data that breaks the state up geographically or anything like that, climate-wise?
In terms of COVID-19 related spread, I haven't seen a data set that specifically addresses that, but yes, there's for-purchase data through the National Association, Oceanic and Atmospheric Association. I think that's NOAA. You can buy that, and you can correlate that to virus spread data sets. But yes, you're absolutely right. That, Doctor, that is an enormous state with widely varying climates.
Great presentation. Any other questions or comments?
Yes,
on
this
our
is
presenters?
Yes, this is Maria Hurt.
Yes.
I have a question from my own understanding. Thank you, Mr. Britt, for your presentation. I want to be clear. I understand the data that you provided. So assuming, to the best of your ability, looking at the data, it appears that two things are contributing to this surge. As a matter of ruling out other options, which is increased socialization, and we see these big spikes of outdoor gathering, which is good. We want people to, of course, be outdoors, get fresh air, but just the mere fact of big crowds getting together outdoors has created, we're assuming that's responsible for a surge, and the seasonality change. So I guess my question is, if I understand that as the foundation, the foundational assumptions we're making, knowing that we don't have the data yet for post-Thanksgiving, and knowing that social gatherings happen over the holidays, there was a lot of travel, there was a lot of families getting together. I guess my question is, what can we anticipate? And you mentioned this, that we can anticipate a surge. You're not really sure of the magnitude. I'm assuming that you're saying that's because of these two factors, kind of the perfect storm coming together: the season, the gathering, the traveling, based on the mobility data sets that you've provided us.
Sure, Dr. Hurt. I will just step back and clarify one thing. I can't point to any social gathering thing that's currently driving this surge. We don't see any mobility data signature to support that. So the social gathering that I think you're referring to would just be normal life activities, things that would be associated with community spread, how our communities currently operate. It wouldn't be any single large gathering. But and not to correct you at all, but what the multiple factor magnitude amplifier that we're seeing here is three parts. One is the seasonality. We've never seen this mobility data signature like this in these temperatures, which we think is going to be detrimental. And then 2 and 3. We've never seen two mobility surges like this back to back or this close together ever. We did have Memorial Day and Independence Day fairly close together and compounding one another, but we've never seen two this close together. And then at 3, we've never seen mobility signatures this large. The Thanksgiving Day was the largest mobility signature we've seen.
Thank you for clarifying that. So given everything you presented, what are your thoughts in terms of what we need to consider to mitigate, if that's even possible, the oncoming surges or surge?
I really wish I could be more help there, Dr. Hurt, but I'm afraid this bell cannot be unrung. It's already happened. We can't mitigate the past at all. So I'm not really, I don't think there's any way to prevent the surge that's coming. It's just, I would encourage this board to find ways to dampen or blunt the effects of it. And I'm not really sure there's a policy action at your disposal that can have a very significant effect to prevent the surge that's coming.
Thank you.
So, Dr. Gocher, I just kind of wanted to kind of bring this full circle, and I know we also have some guests, but I just want to, I'll defer to you. But the thought, I mean, when I saw this, first of all, this was, you know, not something I was, I mean, this is not my wheelhouse. And so, but what it did do is there was at least a correlation between what we've seen and what I've always tried to do is say, how much could we use data to explain what has happened? And even if we don't totally understand the patterns that it represents, to explain what has happened. And then can that help us to look forward to what is going to happen? And that's what I took away from this. And I think and this isn't just for this Board of Health, guys, we're hearing this in the media, you know, with a lot of public health officials. I mean, public health officials are expressing this, and it's being reported in the media, is that we really don't know what we're going to see in the 2 to 3 week time frame after Thanksgiving. But we've seen some of the numbers from a hospital perspective that we're seeing now. You know, I thought it would be several weeks from now that we're seeing these types of numbers. And so, you know, back to kind of the 5 core actions and all of those things. I don't want to detract from the question time, Dr. Gocher, but I just want to make sure you are aware, and I wasn't the one that really arranged guests from the other health systems, but I do see their presence here. And so I just wanted to make sure that they had that opportunity, or if you see fit.
Appreciate that. And if we do have guests that would be, more or less under your update, Dr. Shami, I would welcome their comments at this time. And maybe by way of maybe you could introduce them or sort of let them work through your time to speak, if that would be okay, since you work with them on a regular basis.
Yeah. First, I mean, I'll let these folks introduce themselves, but I'll start with Dr. Brown from Covenant.
Thanks, James, and thanks to the board for giving us the opportunity to speak. I'm Dr. Mark Brown. I'm the Chief Medical Officer with Covenant Health System. And as you mentioned, Dr. Gocher, James, and Frank, who will speak here in just a moment, we work together on a daily basis along with Dr. Buchanan, Dr. Sturdivant, and have been since February, seems like much longer, on working to fight this pandemic. And I don't want to sound repetitive, but I do want to speak tonight in support of a lot of what Dr. Shamia has said. We are very busy this time of year. We're always busy this time of year, as has been mentioned, but we are seeing across Covenant the same type of patterns that James is talking about with UT. We've seen the largest number of COVID patients that we have seen to date within our health system, and it is straining the health system. So we are very glad to have the opportunity to just reinforce the fact that we do see this as a concern for the community, and which is why we are supportive of changing the hospital status to red at this point. But I also want to echo something pretty strongly that James said. Just because we have gone to red status does not mean we are closed for business. And the last thing we want to see is a decrease in the number of people seeking healthcare that need healthcare. I know back in the spring when we had a partial shutdown of the health system across the community and literally across the country, we saw people delay getting care for heart attacks, for chest pain, for strokes that had detrimental outcomes for our patients. So I want to be really clear that if you are having those symptoms, it's still critically important and it is safe to come to our health systems. We're all working very closely with the health department, following the CDC guidelines, making sure we're following infection prevention protocols so that even in light of these larger numbers of COVID patients, we can and are keeping all of our patients safe. So I want to be sure that that message is heard as well. Two other brief points, and then I'll turn it over to Dr. Berline if he has any other additional comments. It's more important now than ever to do the things that this board has been asking the community to do. And I know we kind of sometimes may get some fatigue about hearing about 5 core actions, but wearing your mask, socially distancing, staying home when you're sick are more important than ever. Independent of the data or the trends or the mobility, and it was very interesting to see what you presented, Keith, but it really is more important than ever. It's the simple things that we can do that are going to make the most difference. In kind of response to your comments, Dr. Hurt, it's those simple things that we've been asking all along that candidly, I think a lot of us are tired. We're tired in the health system, but it's important now more than ever because the strain on the health system is greater than it's ever been. And I don't ever want to miss an opportunity to be thankful for my colleagues, Dr. Shamia, Dr. Berline, Dr. Childs, the CEOs of the health system, Dr. Buchanan, Dr. Sturdivant, the ability to work together with these folks across the community. We use the word unprecedented a lot with this pandemic, but we have really worked together in ways that we've not worked as intimately together before. And I think it has allowed us, even in the face of some challenging times, and this is one of those, to work very closely together to assure that the healthcare needs of our community are met, both COVID and non-COVID, and we will continue to do so. So I just wanted to publicly thank my colleagues, those who are here and those who aren't here, and look forward to the opportunity to continue to work together. Thank you, Dr. Gocher.
Thank you, Dr. Brown. Really very good report. And again, sometimes your comment about doing the simple things having the most effect, it rings true. Certainly does. Dr. Shamia, do you have Dr. Berline up? Or?
Yeah.
I'm here.
Yeah, so Dr. Berline is from Teneva. I'll let him introduce himself.
Yes, this is Dr. Frank Berline. I'm the Chief Medical Officer for Quality at Teneva, both the Turkey Creek and North Knoxville campus. And I will basically just reiterate what Dr. Shmia and Dr. Brown said about how we are busy in our hospitals. We are managing. We're working together with our fellow physicians and colleagues across the systems and making sure that we can take care of the patients. We obviously do want to make sure that people with emergent or urgent conditions do continue to seek care. We cannot let them get worse without the care that they so desperately may need. As Dr. Brown mentioned, we're always busy this time of year. We have the flu season, which always starts about now and contributes significantly. Fortunately, I think that we may, I'm hoping anyway, that we'll have a lesser flu season because of our use of the 5 cords, which we've been promoting for some time now. Unfortunately, although we may have less flu, we are seeing more cases of COVID-19, and we just need to remember to follow those 5 cores. Maybe we can reverse this trend that Dr. Shmia talked about before, but we are doing everything we can. We are still available for patients as they need care, and just want to provide for the community and work together among our colleagues. Thank you.
Dr. Braun, thank you very much. Any comments, questions, concerns from the board to our guests this evening? Questions?
Can I just thank them for being here to show everybody in the public that we all are speaking with one voice, that healthcare here is here for everybody, that all systems are working together, and that we really need to, we have to decide as a community, are we going to do what we can to get through this? And the next week or two is going to be very important. And we have healthcare providers among us who are willing to help us, but we want to diminish the numbers that need to get that healthcare. So by following the 5 core actions right now, especially if you've been traveling last weekend, to watch out for signs, symptoms, and to take care of yourself and stay away from other people. Don't spread disease. So I want to thank them for being here. It's really important to hear their message.
Thank you, Dr. Brown.
Yeah, I'd like to echo that. And Dr. Gocher, one other point that I should have made when I discussed the transition to red, and also just want to make sure I recognize these folks, is that Dr. Brown, Dr. Bernlein, myself, I mean, we talk about our teams every day, and I've told you multiple times about our biggest challenge is going to be staffing through this. And there's no question that has become, I mean, that's a bigger issue for us this week than it was last week, because, I mean, even with the 5 core actions, I mean, we still have COVID illness in our teams, in our team members. And that affects our ability to staff, that affects our ability to surge. We just want to, I mean, those folks are tired. We want to recognize everything that they're doing across all the systems, how grateful we are, how grateful we know the community is for those folks. But we also just need to recognize that that is a critical piece of the equation. And if there's illness in them, and whether they're COVID positive or awaiting a test and they end up being COVID negative, they're still out of our staff. And that is a very real issue, and anticipate we'll continue to have challenges that we'll have to navigate through on that.
Thank you, Dr. Shmia. Along those lines, everyone will recall that when New York City had their surge in March and April, that thankfully volunteers from all over the United States involved in various aspects of healthcare volunteered and came into New York City to help solve that crisis. We don't have anybody to draw from now because this pandemic is pan-national. It's as critical in California as it is in Idaho as it is here. So unfortunately, we don't have that pool to draw from, and our own pool is either fatigued, burnt out, or possibly having illness. So I agree. The critical sort of linchpin in this is keeping our personnel healthy and working. Any other questions for our group? If not, thank you so much for participating, everyone, this evening.
Dr. Goetcher, I'd just like to add my thanks too. This has been unprecedented. I know the hospitals have worked really well together. And it's been very difficult for everybody, but they've done an exemplary job. So we are all grateful and thankful for that.
Thank you for those kind words, Mayor.
Thank you.
Any other points of discussion, questions for our group regarding the all of the medical centers data update? Anything more that we need to go over this evening? If not, again, thanks to everyone for really informative presentation. Next item on the agenda are questions for the educational institution. We have presentations that were sent out for the University of Tennessee and also for the Knoxville County school system. Any discussion about that from any board members or Ms. Wagner? Any further discussion on Knox County schools or any amplification of the data?
I think the PowerPoint I sent you yesterday, they had 125 students that were active cases. So I looked at today's data and there's 130 and staff is 60. So that's all.
Thank you.
Lisa, any more schools red? I can't remember.
Powell Middle and Halls Elementary were red yesterday. They turned those red yesterday.
Okay, thanks.
I was looking to see if we had somebody from the University of Tennessee that was, I think someone was on earlier, but I don't see them in my gallery here today.
So I can maybe just briefly comment, just because
Okay.
I was on a call with someone from the Emergency Operations Center yesterday about just general university stuff. And so obviously all of the undergraduates have pretty much gone home. Final exams are going to be all virtual. And so there's probably a small percentage of students that stay behind. These are students that are either international students that can't get home or students that don't really have a home to go to. And so it's a relatively small population. And so I would suspect that the number of students will be pretty low until they come back in January. I think there has been a small uptick in employee cases, mostly associated with community spread, just like we're seeing with everything else. But otherwise, I think the university is generally quiet because most of the population is not here currently.
Sorry, I'm muted. Any more information that we have to share or any questions about our educational institution updates? If not, again, I want to thank those responsible for the reports. And the next item on our agenda then is discussion of our regulations. And in our first discussion will be 2020-1, which is our face covering or mask regulation. And remember that this one does not have a sunset date. So we're just discussing updates, concerns, or questions. And anybody want to ask questions about that, lead the discussion? Dr. Buchanan, please.
Sorry, go back to schools real quick. I know there's been a lot of talk in the public about the number of students in quarantine in the schools. And I just want to reassure everybody that Knox County Schools is working very closely with us, and they're very carefully looking at who should be quarantined and who shouldn't to minimize the number of people quarantined. So they're really doing the best they can to minimize those numbers. And it's not just a kind of a decision taken lightly. They're looking at video footage. They're looking at all kinds of stuff to make sure they're making the right decision. So I applaud Lisa and her team for doing that and trying to make sure they keep as many students and staff members in school as possible.
Just a quick question, Dr. Buchanan, or maybe Lisa would know better. Do you know if Knox County is going to move toward the updated quarantine recommendations from the CDC?
Oh,
that
well,
just came out earlier?
That would be us. Yeah. So yes, we will. We just are updating our staff, and there's some logistics. There's some logistics on how that works because now it's not just a hard 14 days, or it's not even just 10 days. It's this other thing. So for those of you who haven't heard, the CDC is based on data, based on information that what they've seen across the country and around the world. That someone who's in quarantine, who's asymptomatic, can get out of quarantine in two ways. One would be to have a negative test within 48 hours of day 7 of their last contact with the case, or be asymptomatic at day 10 and be able to get out of quarantine that way as well. So that's good news. The day 10 appears at that point about a 1% chance that that person would still go on to develop COVID within the next 4 days. And at the day 7 marker, it's about 12%, 5 to 12% of folks will go on to develop symptoms. So really important for those folks to pay attention to their symptoms and isolate if they do develop them. We will be implementing that, which is, I think, going to be helpful for lots of folks. It's certainly a lot easier to quarantine for shorter time than it is for 2 weeks. 2 weeks is a long time.
And Dr. Gocher, I'd like just to add to what Dr. Buchanan said. I can't think of a better time to have a reset for those guidelines, because we all knew how cumbersome and arguably unrealistic 14 days was. And so given the situation where we are now, if what I was always concerned about is people were so unable to do 14 that they just didn't do much. But I mean, this is very tangible. It has an endpoint if you get tested, and it has at least a 10-day endpoint if you don't get tested. And so this was much needed, and we're going to really need to advertise this. I hope this makes it a little more realistic that folks will be able to comply. Because I know we've all had people that have had to deal with this. That duration of time was very difficult. 14.
So, Dr. Buchanan, has this been something that the health department has or can sort of get behind with a series of public announcements at your updates, or how do we effectively spread that message?
Well, we'll be using our updates to get that information out. We'll be posting it online. We'll be sharing it with our phone bank and folks who answer the phones here and our EPI team, and speaking about it when the opportunity presents itself. All of the guidance on the Tennessee Department of Health's website will also be changed to reflect that, which is where, our website or our TDH's website or the CDC's website is where doctors go to get that guidance. We'll try to send some stuff out to local physicians. Local physicians are challenging to communicate with because some of them are in a network, like folks who work at UT or folks who work for Summit Medical or Covenant Health. But not all of them are in a network that's easy for us to get information out to. So we've been talking about how to get this message out to doctors as well, so that when they're communicating with their patients, they have the correct information, because they want to provide them with the best guidance. So sure, Charity wants to say something now.
Sorry, just real quick, want to add that just to manage expectations, that it is going to take a little bit of time for all of our documents and all of our information to get updated. We really had to wait. We had about a 24-hour preview of what was coming, but everybody wanted to confirm what we heard was happening was actually what was published. And then had to make sure TDH was on board, since we follow their guidance as well. And so both TDH and us are going to work very hard in getting our staff trained and up to date. And then also with getting all of our documents up to date. So we asked for some patience and grace, because that's a lot of information and it's a big complicated change to put out to people.
And then I guess I would say each of us, as we have an opportunity, because I think, at least to some degree, we turn out to be spokesmen. I know I've gotten phone calls from colleagues asking about quarantine. And as late as last Saturday, I went to the CDC website and told them, I think it's going to be 14 days. And I will call that person as soon as this meeting is over and give them the update. But if you're asked about things, be sure that you're up to date with those latest guidelines so you can give contemporary information. Any other discussion regarding COVID-19 face covering regulation 2020-1?
I realize I normally give a complaint report at this time. However, I think complaints have really diminished. It's hard when people call and say, somebody, Mary Smith is not wearing a mask. It's hard to go find Mary Smith. So we don't do that. But really, I think the complaints about that have really diminished for the most part. So that's good news. And certainly, we see signs posted around the community about the need to wear masks. So I don't really have a lot to report. I think I would say certainly not the time to stop this mandate.
Other comments from the board?
This is Maria Hurt. I would just like to say that, we keep emphasizing the 5 core actions, which includes wearing masks. And as Dr. Buchanan has noted, fewer people filing complaints about, businesses or other people not wearing masks. And anecdotally, we've seen, most people in public wearing masks, which is a good thing. I would just like to say, let's assume the best of each other for those people that aren't wearing masks. Let's assume, there's a good reason behind that, rather than harshly judging one another. If most of us wear masks, then those of us who can't, or those people who can't for whatever, or won't for whatever reason, I agree with Dr. O'Brien, and I would assume with all of my fellow board members that we've really got to support each other through this, and keep reminding ourselves and each other that we're not fighting each other. We do not need to be against one another as fellow citizens, but we really need to work together to fight the virus.
Appreciate those comments, Dr. Hurt. Thank you. Any other discussion or comments on 2020-1 this evening? Hearing none, we'll move to sub-item B, which is the social gathering limitation regulation, which is 2020-8. Discussions, questions, concerns.
So I'm going to have Danielle pull that up for everybody, and I apologize for getting this revised version out. I think in order to discuss this, I'll make a motion that we approve it, and when we have a second, we can discuss it.
Second.
Thank you.
We have a motion and a second regarding 2020-8.
So
discussion, please.
Danielle, if you'll scroll down to the therefore section.
Can you make it a little bigger too?
Yep.
Thanks.
Yep, sure. So basically, if we go, so what I did is change the number of people. I can't highlight the number of people from 8 to 10, and went back to the space limitations. And the reason for that was, in talking to Mr. Sanders, the way it was written and trying to write something without the space limitations, it became very awkward to try to figure out everything that you would have to take out of there. So it cleans it up a little bit. So if you can scroll on down so we can see all of paragraph 3, please, Danielle. So, and then again, based on the space needed to allow 6 feet of distance. The square footage obviously is less than 25 for 25 people. That's, and then we kept the language in that was there and related to bars and outside areas. And then I also added, scrolling down to underneath paragraph 5, I added like meetings for like gatherings for therapy and stuff like that. Similar gatherings, that was mentioned last time. And I think that's the only exception I added. All the other exceptions are the same as the previous ones. And Mr. Sanders, I don't know if you want to bring up your concerns at this point, or if you just want to let the board discuss this. But he had mentioned some concerns that he had that he can obviously explain to you better than I can.
So I think in the interest of legally clarifying this, it would be nice, Mr. Sanders, if you sort of started out with your concerns before we discuss this much further.
Frankly, I think that the last draft that Dr. Buchanan issued that had the square footage limitations on it addressed many of the concerns which I had earlier had in my discussions with her, because my concerns were essentially what you all were wrestling with the other night, which was that there was too much ambiguity in the terms. That is, what is a group? What is a gathering? How do you define it? But when you start saying numbers of people within an area, that provides an objective definition that anybody who reads the regulation can understand, whether it's someone trying to enforce it or, more importantly, someone trying to follow it. And that's what my ultimate concern is to ensure that the citizens who are trying to follow this regulation or obligated to follow this regulation have something objective that they can understand and follow. And I believe that having a square footage or a number of people within a certain square footage element to it does resolve that issue.
So, Mr. Sanders, several of us received an email. I forget, they all blend together. I forget whether it was today or yesterday, from a business owner that was aware that this was coming up and really was concerned about the square footage. And I think his or her concerns were about, my business's total square footage versus, what I would need to do. And I guess my question to Dr. Buchanan or Mr. Sands is, does the number of people per 360 square feet address that issue? I think it does, but I'd like to hear from us.
I'm not sure whether I'll go first since I have my microphone off or my mute off. I think this pertains to any 360 square foot space, but just as if you have a business that's larger than 300 square feet, then it would be, you might have two 360 square foot spaces within the area or whatever. And as long as the criteria are met with any one 360 square foot space, that would not be a violation. Also note that we did add that sentence in about at the end of each of paragraphs 3 and 4 regarding that within the 360 square foot space, people not residing in the same household are at least 6 feet from each other, then that would not be a violation either. And that was to try to take into account the different configurations that 360 square feet could have. And you could theoretically have a space that is 2 feet by 180 feet, for instance. And in that instance, obviously, it wouldn't make sense to only have 10 people standing in a line somewhere.
I would have concerns about the flexibility of this. I think that that last sentence, as well as the 360, per number of people, addresses that. But again, I would like to hear from others to see whether this is something that is doable by the community, doable by businesses. And maybe Mayor Jacobs, you might give us your thoughts on whether this is something that's workable for your discussions with those in the community and businesses that might be affected.
Dr. Coach, I mean, it's complicated and confusing. I would feel much more comfortable if this was adopted as a recommendation. The other issue with it is we have, there's so many exceptions that we have to include for legalities and constitutionally that it really waters down the overall impact of this regulation. If a lot of these things are things that we cannot as a board constitutionally regulate, and that's one of the issues that I have with it. If you're going to regulate it, it has to be effective, and I don't know that this does that. If this were a recommendation, we would be able to have much more concise language and I think alleviate some of those concerns. And it is going to be difficult because, 360 square feet, it's 9 by 40 feet, it's 12 by 30 feet. It's all these different measurements. How do we know that people are from different households? How do we know all these things? So as far as any sort of enforcement, and I understand, the idea is to not have big gatherings, of course, but I'm afraid that the enforcement would be pretty difficult.
Thank you, Mayor, for those comments. Any other points of discussion?
I would echo actually what the mayor said because of business. I'm a little concerned because of some of our restaurants and how you would have those different combinations of square footage with groups of people and knowing how to do it. I really want to minimize people gathering right now, but I'm not sure how to legally do it without causing issues or finding a way to even enforce this. That's my biggest concern with it right now. But I really would like people not to gather. And maybe a recommendation may have to be the way we go versus a regulation that we're going to try to get people out trying to enforce this.
Along those lines, Dr. O'Brien and others on the board, I have some concerns about this. I certainly understand the reason why we're looking at this, because we have something that's out of control. I'm concerned about pushback. I'm concerned about people looking at this and willfully disregarding it. We had actually another one of the letters this week where somebody was against what we were doing and not only was upset about it, but willfully acting and asking others to willfully disregard it as an act of defiance. And, that's so counterproductive. So a recommendation rather than a regulation may be easier to talk about. Our recommendations for the 5 core actions are actually much more powerful points of discussion than this is. This is part of one of the core actions.
I'm sorry, sir. Just to put this in context for everybody out there. If anyone is a sports fan, the lane on a basketball court is 15 feet long and 16 feet wide. That's 240 square feet. There are 10 players on a basketball team. Anyone that's ever watched sports realized if you cram 10 players into the lane, that's a lot of people. Okay, so we're talking about an area that's about a third size bigger than that. This is really common sense stuff, that people should realize, and we have repeated over and over again, about the physical distancing, keeping 6 feet away from people to arm's length. So this is one of those things that it's great intentioned, but it's really kind of common sense. And I agree with you, Dr. Gocher. I think sometimes what happens then is people get mad because you're telling them what to do, and then they do the opposite of that. And that's certainly not what we want. We want, as Dr. Hertz said, we want everybody to realize that we are all in this together. This has reached a critical point. So let's all work together and act responsibly and in a smart way.
So,
comments, question?
Yeah, Dr. Gocher. So from the prior meeting, I can't remember. I do recall that during the meeting, I think Nashville had announced that they had, like, you know, a gathering size policy that went into effect literally while we were in the meeting. I believe Shelby has done something, but I believe those are regulations. They're not just recommendations. Does anybody know?
Yeah, they are regulations. They're actually public health orders written by the public health officers in those respective districts. Actually, the language I previously had, I borrowed from I think from Davidson County on their definition of gathering that we kind of got hung up on. This is not, these aren't easy to write, to be clear and understandable. Certainly the intent of this is to tamp down gathering and keep people from getting together and spreading. You know, we've been encouraging people to not do that, encouraging people, and we now have our highest case counts and way more deaths in citizens of Knox County than I certainly am happy with or comfortable with. So, but of course, we'll do what the will of the board is.
So, Dr. Gocher, I would just add that, you know, we've had recommendations that we've passed before. I think it gets back to intent. Dr. Buchanan used that word. Others have used that word. But we've had recommendations that have, quite frankly, barely gotten covered by the news media, which is in some ways, one of our primary vehicles of trying to educate the public. I mean, you know, the hospital systems have done Facebook Lives. They've done joint press releases. As Mayor Jacobs has said, I mean, people have gotten the message by now, but our situation is evolving. And so you know, I'm more focused on intent than I mean, there will not be a perfect regulation written about this, I think, but I don't want to kind of miss the big picture, which is the intent, and then not act. And it does reassure me to some extent that Nashville and Memphis have done something, because guys, we're right with them in terms of, I mean, if you take a proportional look at our population and our hospitalization rate, you know, Vanderbilt just yesterday announced something about non-essential procedures, and in talking with them, they're going through these same discussions and thought processes this week that we are here in the Knoxville district. And so I don't want to water down or lose that intent, because I do think this is fundamentally important at this time.
Dr. Shami, I agree with the premise that, you know, we need to try to seize this moment to do the best good that we can. I guess personally remain unconvinced that anything we do is going to have any bearing on the next few weeks, if not even the next month, and that in fact it may lead to more discord and maybe have things even worse in terms of crowds and social distancing. You know, I just remain concerned about that. Other thoughts or discussions? I don't want to hog the podium here. I want to have input from everyone on this.
This is Maria Hurt. Yeah, you know, listening to both sides of this, a couple things that come to mind immediately are, you know, the mask regulation. There's a message sent with a regulation versus a recommendation, and we understand not everyone is going to, you know, comply, just like everyone doesn't comply with the no smoking. You know, in public places, or everyone doesn't comply with wearing a seatbelt. but the measures are put in place to protect each other. And so I guess to my colleagues is, how is implementing this regulation, which says, look, people, you can go to church, go to weddings, go to funerals, go to school, gather in your homes. We don't want to infringe on your rights, but we're wanting to make very clear the importance of, just like mask wearing, keeping physical distance with people that are outside your immediate household. So I guess I'd like to ask that your all's thoughts about, how does putting this in place differ than putting the mask ordinance in place? We understand enforcement is always going to be a challenge. It just is. But that's not, I agree with Dr. Shamiya, that's not our intention. And I don't think it's been any of our intention to fine people or, put them in jail. It's just not. But the intention is to make it very clear the seriousness of following the 5 core actions and formalizing this as a policy, rather than just, we can all recommend things till the cows come home. But so I'd like to know what your all's thoughts are about how this seems to differ to us than, for instance, the maintenance regulation, I should say.
Comments?
So
I guess Dr. Hurt. Oh, Dr. Sousa, please.
Yeah, sure. So I think this is a hard one. I mean, I'm struggling with this because I agree with the one side that, is enforcement going to make this better? I don't know. I certainly read plenty of emails that came in over the last few days saying that, just as Dr. Gocher said, that, okay, well, we're going to just rise up and do worse things. Alternatively, if you don't have any teeth behind it, and I think I was the one that said that for the mask mandate, then you can't enforce it. And so I think we're in a little bit of a bind here as to what the right answer is. I don't know if that really helps with anyone, but just kind of where I'm at, that I don't know that I'm completely decided either way. I don't know if Dr. Buchanan, I asked her, I think 2 weeks in a row before we let the last group gathering policy sunset, have you had complaints? Have you had, what's been going on with it? And one of her comments was that it was difficult to enforce. And I don't know if you think, Dr. Buchanan, this one has better language in it, which I think it certainly is more thorough. Do you think that this would be useful?
So I do grapple with what's the right thing for us to do. What's the thing that will work? What's the thing that will make a difference? Because I feel like we've been talking about doing all these things and practicing the 5 core actions till we're blue in the face, and our cases keep going up. And so, I know people are tired and are tired of practicing the 5 core actions and tired of COVID being around. This one is actually written, except for, I think, some of the language in the exceptions and stuff, is actually, I just took the language from the previous one, changed the number to 10, did some math and plopped it in there. So it's not going to be any easier to enforce. I mean, it's hard. You're right. And that's why the other one I wrote, just saying gatherings of a set number of people. But then that got really foggy and confusing too. I'm discovering that policy work is challenging. I think, I want us to do something that's meaningful. I don't know that this would be meaningful. I think it does send a message, like Dr. Hurt said, to do a regulation versus a recommendation. But it also, there's a portion of our community that they're just going to push back against that. I think we're caught in a difficult place. I'll just be honest. And so it's not any easier to enforce. Nope. I wish it were, but it's not.
Is that really our intention? No, that's not a rhetorical question. Is that really our intention? Is to enforce? I mean, technically, yes, it's a regulation, technically, yes, but I mean, we don't have the masked police roaming around Knox County, and we don't want that. And so again, it comes back to what is our intention, and does a regulation not have more weight, meaningful weight in terms of messaging than a recommendation? And again, not rhetorical. I would really love feedback from everyone.
I guess given the complexity of it, I mean, my thought would be if it was blatantly and obviously being not followed, and there was an entity that was willing and able to enforce it, and in those situations, which are probably the highest risk situations, and they don't fall in the exceptions, then yeah, I would like to see it enforced. But we're not going to be taking a tape measure and counting people, and I mean, it's going to be, if it's not dramatically being broken, then it's probably not going to, I mean, if there's someone willing, it's still probably not going to be enforced. But in the situation where it is significantly been disregarded, then yeah, I mean, I really don't want to send that message that there would be no enforcement piece to this whatsoever. And I think we said over and over that we're not, this board specifically is not the group that can ultimately implement that or decide that. Our role is different. Our role is to decide and vote on what it's going to be. And there are others in the community who would decide about enforcement. But the reason I like it to be a regulation is that if it's far away been disregarded, then yeah, there would be a situation where it could be enforced.
So I guess go ahead, Dr. Drake.
Yeah, I am for it being a regulation also because I think it's worked in Nashville. I've been following that pretty closely, and people have not been gathering like they were before. And we don't want to be in 2 weeks say we wish we'd have done that when the spike gets really high. We have to think that it might reduce the number of cases. So I would be for regulation.
I guess my comment about, there was a question brought up about the inherent differences between 2020-1, the mask regulation, and 2020-8. And my thoughts on it are that the mask regulation probably offers the greatest amount of benefit with the least amount of intrusion. And of course, there are many in the community that would say, they would argue with that and say, this is a big intrusion. But the reality is it's probably the least intrusive for the most benefit. But the regulations are going to be very intrusive to business. They may not be intrusive to an individual, but they'll be intrusive to business. I think those that choose to want to comply with it are going to be trying to figure out all of these geometric variations and all this sort of stuff, and it's going to be frustrating, I would think. I guess I'm more of a favor of recommendations because one, I see that we're going to see a change in the next weeks in the cases. I think the die has been cast. We may be looking ahead at a month or 6 weeks from now, but I don't know that in 2 weeks we're going to look at this and say anything has gotten any better. Dr. Shimi.
Yeah, Dr. Gocher, on the die has been cast piece. I mean, I want to kind of clarify on that yeah, what we see in 2 weeks, what we're talking about today will have no impact on 2 weeks. We know what happened, Thanksgiving gatherings will, but this will not. But I think the point of earlier is that, we may be in a position if we really do spike the way that I'm concerned that we may, the degree that we may, then when we act and react and do something, then we're yet again behind. And so the point of that is that we're reacting now, anticipating a Thanksgiving spike and trying to dampen the effect that happens after that Thanksgiving spike. Now, I understand that we're in a position right now where anything we talk about, the ultimate effect that it dampens, because it's not going to reverse. I've said before, I think the next 2 months are going to be rough. I just do. and we're not going to be able to fundamentally turn that around. But any way we can dampen it is what we want to do. So I don't want us to lose sight of the timelines that we're talking about here. Now, I think it's a different conversation to say, you know, the enforcement piece and how effective piece it'll be, but the time to act to try to have an impact on what happens after the post-Thanksgiving spike is now.
Other comments, discussion? I think we've had a good discussion to this point.
I'll just throw in, again, I think this is a difficult balancing act between regulation and recommendation. It's one of those things that, especially in the business community, that's where the primary enforcement would have to be more than other places and other people. It's not going to be the sheriff or the police. It's going to be that individual business owner who has some people gathered in a certain space and having to sit there and do the counting. And I do have concerns about that. We do have already our regulation for 50% that we put into place, which I think is much more reasonable. We had broad support by everybody here for that. So I unfortunately am one that's maybe not going to go toward the regulation side of this, but would definitely recommend to the community. The biggest thing we got to tell our community is that, as Dr. Shamia just said, we have a tough time ahead. We need to do everything we can to help each other. We have a vocal minority, and it's a minority who are against things, but they are people who are loud, and we don't want issues with anybody. We want people to all support each other. So I would just more go that way and do a recommendation at this point, and just tell people they need to be ready for what's coming, and they need to be, you know, have that individual liberty to act responsibly right now. That's what we need. So just a reminder.
Thank you. Other comments, discussion?
Just an idea or question. When we talk about the businesses, and I don't know what you're thinking, if restaurants are the one that we're most concerned about, and they're already covered by a 50% from the last meeting, and I understand depending on the size of the restaurant, 50%, it could be a small restaurant, a bigger restaurant. Does that kind of resolve the concern that if they were actually excluded and referred to the 50%, and then that, because that was the intent of that one, or are there other businesses that you're group in that you, if this remains a regulation, that you guys are concerned about?
So Dr. Shamia, we've had comments in emails about big box stores versus small businesses and how small businesses are maybe discriminated against, and nobody talks about big box stores. My understanding of at least most of the major big box stores is that, number one, they require masks, and number two, they typically will have aisles or one ways or whatever to try to keep people distance from each other. How effectively that works, how they keep their numbers at a reasonable amount, I have no idea. And I would assume that, like most entrepreneurs, if they could have more traffic, they would accept more traffic, and that may go against that. So it may not be as much of an issue as it is for these big box stores, which we've never looked at in a way.
So I guess this is just, you know, this is about people gathering for one thing. This isn't about a whole bunch of people in a restaurant who are sitting at different tables having dinner, or people scattered throughout a store who are shopping. This is about people gathering together, you know, either, you know, for a holiday party at the office, or for a baby shower somewhere, those kind of things. So it's about people gathering for the purpose of socializing. It's not about people running errands or having dinner with their families at a restaurant separately. So that's not what this is about. I think it seems like the conversation has gone that way. And again, I'm not, you know, people need to be able to understand this, interpret it, and then follow it. So if it's not clear that it's not about those things, then, you know, maybe it's just not clear enough.
Dr. Buchanan, this is Maria Hurd again. I'm glad you brought that up, because my reading of this, my understanding of it is it's really the other arm of the 5 core, one of the other arms of the 5 core actions. We've put you know, masks in place. Now we're saying we really need everyone to observe social distancing, 6 foot, and to avoid large gatherings or larger gatherings of people, not restaurants, not store shopping, not going to church. We're not talking about that. We're talking about specifically, basically parties or celebrations, I should say. This is the physical distancing arm of the 5 core actions that we continue to ask our fellow citizens to observe. And I still am unclear how this is different than the mask regulation. I hear you, Dr. Gotcher, when you're saying, you know, you believe, you know, I'm always making notes here. You believe masks are less intrusive, but with an increased benefit. I'm not convinced that this can't also be a benefit. It's most people, if we go to the store, for example, are very conscientious about, you know, trying to keep some distance between them and other shoppers. Restaurants are doing their very best to, you know, to also, you know, make sure people are keeping their distance if they're, you know, not within their own party. I just don't understand why. It seems to me we're making this more complicated and more irksome than it needs to be.
Sorry. Further discussion?
One technical thing I just noticed looking over this potential regulation, just if we pass this in one way, shape, or form, Section 5D, it says Knoxville City and City of Farragut. They should be the City of Knoxville and the Town of Farragut. A little technicality, but we want to make sure it's right. I just noticed that.
As long as we're taking a look at some typos on page 5, number 11, need to correct from 8 to 10 people and COVID-19 to ID instead of ED.
Yeah, the 8 was caught and has been corrected, but the COVID I didn't have, so thank you.
One other thing to maybe update also, I think the last version I saw had the benchmarks from last week still. So I don't know if we would want to add in this week's benchmarks. And then I guess just keeping in mind, I think that we all got the most recent White House task force recommendations, and this kind of falls squarely into what some of those recommendations were for what Tennessee as a whole needs to do. And Knox County is in that red zone as well.
And I'd just like to add to that. I don't know if you guys did get a chance. It's the one from November 29th, but the degree of the recommendation and the kind of the description of the concern over the situation in Tennessee was, I was quite dramatic where they came out. And so I think one important piece of that is, you know, very clearly talking about what those who are over 65, the types of precautions that they should take. And maybe we talk about that in other business, but I do want to highlight that. But it's very clear the level of concern expressed in that report from November 29th was like orders of magnitude higher than what it seems like had been expressed before.
Further discussion? So one general thing that I guess I could put out, is there a consensus? Is there a feeling that this might be approved with some changes. Are there any changes that any of us see in this regulation that would be reasonable in amending it that might make it more favorable? Or are we prepared to vote on it as it stands?
I go back and forth every time somebody speaks. 1 minute, I'm good with regulation. The next, I'm good with recommendation. I would love maybe a little bit more explanation by Dr. Buchanan. That might help. But I don't know what you can say that you haven't already said. So
I'm not sure. Yeah, what would you, what do you, what explanation? I'm happy to try.
Specifically for outdoor gatherings, it's one that I keep an eye on. We had talked previously about limiting gyms in particular. And so when it comes to outdoor gatherings, I believe you, or maybe it was Mr. Sanders, had mentioned that as long as folks are keeping at least 6 feet of distance, that the gathering size isn't a concern. Did I understand that correctly?
Actually, go ahead.
I'm not sure whether I said not a concern. What I was getting at was simply that the 6 feet was an alternative to the square footage when the square footage was arranged in a certain configuration. I felt that we needed to somehow narrow it so that, again, you wouldn't have people, say, standing in line for a theater. Not the theaters are open, but that type of idea. People aren't standing in line and violating the rules because they're stretched out over a very long distance and not within 6 feet of each other.
See, but then to me that I thought the spirit of this is to avoid people getting together socially, and people standing in line wouldn't be people getting together socially.
Well, okay, I understand. I'm not here to advocate policy. The policy is entirely up to you. What I wanted to be sure of is, first of all, that the directions coming from the board and the regulation are clear so that people know what the regulation says, and also so that, frankly, they're not absurd. You don't want, again, theoretically, if you had a 1 foot by 360 foot area, you could have people spread out anything less than, you had 11 people in that area spread out roughly every 35 feet or so, and it would violate the rule. That's not your intent, I don't think. So I want to be able to accurately express your intent, or help you accurately express your intent. But as to the substance, I have no opinion whatsoever on the substance. I stay out of that arena.
May I ask a question to Dr. Buchanan? Have you heard anything from Dr. Caldwell or the Metro Nashville folks on what they've done? I know they actually have like a licensing for groups for 8, or any issues with how they've dealt with what they did. I mean, it's brand new, but have you heard anything?
Honestly, no. We don't. There's not a regular update of that sort that we have. And so, no, I'm not sure. Yeah, and I believe Shelby and Davidson maybe also have they actually received some CARES funding that we talked about last time that we aren't eligible for, and they've used that CARES funding to do some pretty creative things, and they've created people who approve your event. I mean, then that would take a whole, just ask anybody who approves events or gives a parade a permit. It takes a whole department to do that. And we don't have that capacity. So they've done some, and so I think somebody talked about last week, the Shelby County is doing some small grants for businesses and stuff like that, which is great. And it would be lovely to be able to do those things. But with our limited funding, we haven't been able to do those things. So unfortunately, next pandemic, because I'm guessing with this census will be probably over 500,000 and will qualify for some other funding. I don't want another pandemic to happen, but our qualifications for some things will go up.
Hopefully, Dr. Buchanan, that pandemic will be 100 years from now. We don't know that, but hopefully that's the case. Any other discussion on 2020-8.
Dr. Gutcher,
Yes, sir.
you all have not set, unless I missed it, their sunset date for this. So the last paragraph on the regulation, you probably need to indicate some sort of sunset date on it before you vote on it.
So to the board, discussions, thoughts about a sunset time, a reconsideration time for this.
Yeah, I'm gonna have Danielle share it again because I don't remember what we said the effective date was gonna be, or so just down at the bottom. Thanks. I can't remember, I'm sorry.
I think it was left blank if I remember correctly. Oh no, it was December 4th.
It would go in effect on December 4th. Okay, so that's 2 days from now. Sorry, just trying to. And then, okay, so there was no sunset date. Okay. Correct.
Just for
go ahead.
Just for clarity, can you scroll back up to the paragraph having to do with private gatherings? Thank you, Danielle. I forget which paragraph it is, but I just glanced at it as it was going down.
It's not, I don't think it's broken down that way anymore. Private and public. Oh, wait.
I saw
paragraph 4. So again, that's the same language we had in the previous one. And so a public gathering is something anybody can go to. A private gathering is something you get invited to, which could be an office party or a baby shower or something like that. So private gatherings occur outside private homes in office buildings or other places.
Danielle, can you scroll down in 5? I think it's paragraph B. I just want to look at it. Maybe paragraph C. That's places of worship, funerals and such. Private dwelling places of residence encouraged. Okay.
Yeah, this is Maria. I'd like to point out that I think almost every clause there says, every exclusion clause says, but we recommend, like, this situation is exempt, but we recommend. So we already have a recommendation built into something, which again, I think has more weight.
Thank you. So we are still, I think, discussing a sunset or a reconsideration date on that. I see the date that it goes into effect, but I did not see a termination date on it.
But no, I purposely left that for the board to decide.
Okay. So discussion on that.
So Dr. Gocher, I mean, we mentioned at the last meeting, just based on the understanding of the virus and transmission and where we are in the pandemic, and of course, not knowing if once we get to a vote whether it's going to pass or not, it makes no sense to do it any shorter than 4 weeks, in my opinion. And that just, in 2 weeks, we will know really nothing about its effect. And so that would be just the act of going through it just to go through it. So I would recommend 4 weeks.
I agree. And that'd be consistent with the 2020-7, I think, was the other one.
So that, right. So 4 weeks from now would be December 30th. Is that right? Somebody make sure I'm right. So that takes us through Christmas. Almost.
Can we offer that as a friendly amendment?
I'm sorry. What?
It's the 4 weeks from the date of implementation. So if it's the 4th, then you're doing 28.
Okay, sorry.
Yeah, but we take it out to the 1st of January, sometime early January. Is that what you're saying, Dr. O'Brien?
Yes, it would take you to. I don't have my calendar right in front of me. Like what, the 2nd of January?
Yeah, I mean, I don't have it. Just to clarify though, that the way we do this with our meetings is that we don't try to align it with the meetings. We just make sure that whatever meeting we have that precedes the expiration, we just have to readdress it at that meeting, basically, right?
Right. So
Be
4 weeks
first.
from Friday is January 1st.
So I guess we would need the person who offered the motion and the second to agree on that, and then we could add it on as a friendly amendment. And it's been a while. I don't know the people who made the motion and seconded. Speak up, please.
I did the second, I believe, and I will
I'm fine with
accept
that.
it.
So if we have consensus among the person who made the motion and second, we can proceed with a friendly amendment, if that's okay with everyone.
I just want to state the obvious that takes us through Thanksgiving. No, Thanksgiving's already happened. Takes us through Christmas and New Year's.
So if everybody's in agreement with that, we have a motion and a second for 2020-8 amended to have a reconsideration or expiration date on it. Any further discussion on any of those aspects of 2020-8? Hearing none, since we're ready to vote. So Narda, if you would conduct a roll call for us on 2020-8. But before any discussion, anything we haven't covered or need to cover? If not, since we're ready to vote, so Narda, again, if you will conduct a roll call for us.
Yes, sir. This is Narda Capiccelli, and we're voting on 2020-8. Dr. Drake?
Yes.
Dr. Gotcher?
No.
Dr. Hurt?
Yes.
Mayor Jacobs?
No.
Dr. O'Brien?
No.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
Dr. Buchanan?
Yes.
Okay. 7-3, it passes. Thank you.
Thank you. And thanks to the board. Thank you all for heartfelt discussion. If there's no other discussion on that, we can move to item 11, which is a proposed amendment to our Board of Health rules. Dr. O'Brien, you have the floor.
This proposal I have is just to add one thing that was talked about by our public forum, kind of going halfway. What I was proposing is that at the end of our public forum once a month that we set aside 15 minutes of time available to us as board members to respond to questions or concerns expressed during the public forum, not necessarily in a back and forth discussion, but at least a period of time where we could say to, Miss Garrett or Miss Juno, here's what we think, or I think about what you said, and here's the reason we may look at it a different way. So I was looking just to add a 15-minute public forum board member comment period that we could use or not. And this would allow at least some response back, more than what we might do in our email traffic, et cetera. People noted that they don't get a lot of emails from us. Well, it's tough when you get 600 emails and you're trying to go through them as best you can. You see a lot of the same people, a lot of the same thoughts. I applaud people for their passion. But I think what I want to do is just offer something up of us responding back to the people out there. So that's what this is just to amend the rules. And I've sent that in for consideration to add a 15-minute board member comment period to public forum. And if you need to show that, I don't know if you all have that, Danielle, with the red lines to show what that is.
We're gonna share it.
Okay. So basically, if you look at the second red area, that's where we would be adding a comment period for us. Again, may not be used, but I think it may be worthwhile to say somebody's name. That's a good question. Here's what data shows concerning what you asked. Many times we have people just making pronouncements. There's not much we can say about that. But with a good question, we might be able to give a good answer, contemporaneous.
So I read this, I guess, yesterday or maybe earlier today, and I would be supportive of this. I knew that certainly trying to wade through the hundreds of emails that we routinely get on top of our regular responsibilities is challenging. I think this may be a kind of a way that we could still address some of those questions that we're getting and maybe reach a bigger audience with instead of answering individual emails constantly.
So I'd like just to propose that we amend our rules to include this verbiage, and hope somebody might second me.
So I'll take that, Dr. O'Brien, as a motion. And do we have a second?
I'll second.
We have a motion and a second. Further discussion. I'll put my 2 cents in that. I think it's a good idea. It allows for a little more exchange of ideas, although not a completely free back and forth exchange. That might be really time consuming, but I think this will help some. Other comments, questions, or concerns? If not, sensing that we're ready to vote, Narda, if you will run through our roll call, we'll do a roll call vote on this.
Yeah, this is Narda Capitelli, and we're voting on the proposed amendment to the Board of Health rules. Dr. Drake?
Yes.
Dr. Gotcher?
Yes.
Dr. Hurt?
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
And Dr. Buchanan?
Yes.
That passes 10-0 unanimously. Thank you very much.
Thank you. Thanks, board. So we're in the other business section. Anything that we need to discuss in other business? One point that we might want to briefly discuss, because we've had some topic-driven discussion in the past that I think is a good idea myself for educating not only us as board members, but certainly the community in a wider sense. And are there areas of discussion that we need to do information transfer to the community that would be valuable? Thoughts about that from our board?
One thing that I shared with each of you, and I think I may hold off showing, but I'm going to bring it up to the public. You know, a lot of people use social media. They believe in certain videos from certain areas. Well, I would like to ask the public to look at the BBC. I think of them as a pretty even-handed organization, and they have a video that is a news video made in St. Louis by Dr. Kenneth Remy. And what Dr. Remy talks about in 2 minutes as an intensivist is his experience having to put breathing tubes in for people. And he got frustrated in dealing with that and made a brief video that the BBC did an article on, did a story on. So if you want to search for that, and it's basically what it looks like to be that person getting a tube being put in their throat. I have done that for 30 some years, putting that tube in people's throat. It is a emotional thing. It has been for me in the past doing that, knowing that in many cases, I'm the last person that they're seeing and talking to. And I just want people to understand this is something very real. It is something that as a physician really hits home, and seeing this physician at Washington University show his pain and his love of people, and trying to get people to understand it's not just about you. Oh, I'm fine. I'm not sick. Well, you may pass something that causes that next person to get that tube stuck in your throat. And having been that person doing it for years and years, you know, I want the public to understand what it means, and my personal memories of people looking up at me for the last time. And I know Dr. Shamia has done that. It's really something that bears, it's a heavy burden. So I want our citizens to realize this is real. Take a look, search the BBC videos for this article this past week, and take a look for yourselves. I'm not going to shock you with it here, but I think we need to educate a little bit more. We need to point people in the direction of good information. I do have concerns that a number of our citizens are using social media silos. They're getting all their information from one location or one type of place that kind of takes them down a certain way of thinking. And I think we need to have a little bit broader look at things. And I think the BBC is a good place for that, where people don't think right versus left, but good information. And we as board members need to find things like that and maybe point that out so that the public might look at them and do so with an open mind. So that's just something I'd like to bring up tonight. Thanks.
Thank you, Dr. O'Brien. I had two thoughts, and I think it certainly welcome opinions and other thoughts on this. But one of the points that I thought would help us in clarification and also help the public is the psychiatric and psychological aspects of this whole pandemic. And to that end, Mayor Jacobs, we really appreciate the information that you brought forth to us from the Regional Forensic Center. It's good data. I think that the medical implications of that data need to have discussion and perhaps a series of guests, or a guest at one point may be able to help us clarify that. The other sort of hot topic that I think the public may need help with, and it would help us, I think, in terms of kind of a quick update, is laboratory testing. There are a variety of tests. There are issues of false positives, false negatives, amplification of tissue, viral particles that are not viable versus viral particles that are. There's a lot of discussion amongst members of the public, and a lot of information out there. I would really love to see that clarified, and perhaps one of our hospital systems, Department of Pathology, people who are involved in laboratory science, could give us a quick update on that. And I think that would be welcome to us, but it'd be welcome to the public. Thoughts on that, or any other topics that would be nice to help out with education?
Dr. Gocher, I never know the role of, bringing people in to educate the board versus this forum to educate the community. I mean, we are functioning as a board primarily, but certainly the vaccine, you know, I mentioned at the last meeting that you know, the news could not be more favorable in terms of the speed that these were developed and approved, or they're going to be approved. But there's a lot of people have a lot of legitimate questions. And honestly, that is you know, as much as we talk about everything that COVID has affected, you know, we need to be thinking about how do we get ourselves out of this? And the vaccine is, not everybody's going to take it, but you know, the more people who take it, the sooner we're going to get back to what is some sense of normalcy. Because ultimately, the other thing we can't, back to the mental health piece, we've got to keep in mind, just I mentioned the next 2 months, and we tend to focus on the regulations and all that, but COVID is going to take its toll on people, whether that is a health toll, an economic toll. I mean, you know, it's going to, a lot more people are going to feel the effects, maybe indirectly, but feel those effects well beyond the regulations. So the more we can get people to understand the vaccine, answer legitimate questions about it, and then have people vaccinated as it becomes available, that's to me one of the biggest, most important things we need to focus on. I just don't know how much of that happens here.
I would certainly agree that if we have a sort of a special order or point of discussion, that's got to be number one. The public wants to know, and we all want to know how soon it's going to be available, how soon it's going to have a significant effect in the community, how soon we can get back to normal. That's the question everybody's asking. That'd be a great topic, James.
I had I'm sorry, Dr. Gutcher. Just in general, I had a fascinating call this week with a company here in town that does research on lipid nanoparticles and liposomes. And we got to talking about the vaccine and how it's different from conventional vaccines. And it was just a fascinating conversation I had. So I think that would be very beneficial for the public to hear even some of the technology behind this vaccine, because it really is fascinating. And it really is a testament to modern medicine and technology.
I'm glad you bring that up, Mayor, because I think it's the more information the public can have, the more confident they'll be about being open to being vaccinated. I mean, we talk a lot about, you know, vaccines coming, but people have to be willing to be vaccinated for it to work. So I agree with you.
Maybe our next meeting can be about what we've just talked about, put more emphasis there on these items, on the vaccine, on some education, versus we can do our reports maybe a little shorter and get into some of these other areas. I think it's really important to encourage vaccination, but people need good information. And these vaccines, at least the initial information on them, is phenomenal compared to prior vaccines. I cannot wait to get mine. And I think we want people out there to understand how important it is. You want to get back to normal? This is your way there. And we need to give them good information so they make good choices.
To Dr. Buchanan, if we were to have a short session on vaccines at the next meeting, is it a matter of just putting it on the agenda, or is there, there are other things we need to do to make that happen?
No, the agenda is the board's agenda. So whatever items you want on the agenda can be there. Dr. Gutcher, you can add that. That's, I mean, we send it out beforehand to get your input, see if you need to add things, or NARDA does. And so, no, that certainly can happen. We actually have an organization that helps, is actually involved in several trials, vaccine trials here in Knoxville. And I'm not sure, Dr. Smith, who works there, might be willing to come and talk about. He has a pretty broad breadth of knowledge about vaccine, because they don't just do testing for COVID. They were involved in H1N1 vaccine and lots of other things. So He's somebody who might be willing to come and kind of talk us through all the different vaccines. I'll be honest, the information about vaccines and what's going to be available when is changing daily. You know, one minute we're getting a big bunch of vaccine, the next minute we're not even getting that kind of vaccine, we're getting another kind, and it's just changing a lot. So the challenge with, they can talk in general about the vaccines and what they're going to do, but who's going to get what when is a moving target, unfortunately, until it really starts arriving and we actually have it in our hands to administer. We don't know exactly what we're going to get.
Well, and to that point, I mean, there is a hierarchy set, you know, it's going to be frontline healthcare workers first, but we've also I mean, we need a runway of conversation about the vaccine. It's you know, going to take more than one conversation, so we can do our part, understanding that we won't be able, because we're hearing the same things and about it changes every day, so we won't be able to commit to a date, but we know that it's coming. And it kind of changes the narrative a little bit. I mean, we all need to be looking to, I mean, you know, the members of this board are just like everybody else. We grieve for that life that we had before all this in a variety of ways. And so the more we can get our head in that space, the more we'll be able to navigate through these difficult 2 or 3 months.
Absolutely agree with you, Dr. Shmi. I think that we talk a lot about fatigue from everything. And I think, you know, when we see a light at the end of the tunnel, some of that fatigue will hopefully naturally lift, and, you know, we can get through it. So that's a great observation.
With that in mind, and as the agenda is being sent out, I would offer to include that as an agenda item in the manner of vaccine update. We may have that as a recurring topic for a couple of meetings as this starts to unfold, because it is rapidly evolving, but it's of interest to everyone. But it's, as a public health measure, obviously needs to be promoted. But I think understanding how it works and such to some degree is going to be very helpful to the public. Any other points of discussion, things to go over this evening?
I know everybody, or I think everybody got the White House report. I'm not sure if anybody wants to bring up any. I know Dr. Shamia, you mentioned it earlier. The language is certainly much stronger than it has been regarding people over the age of 65, and even folks who are under 40 who traveled for the holidays. They're recommending that you actually quarantine for a while, for 14 days after you get back. And pretty strong language about the need for statewide efforts as well in the report. So I didn't know if anybody had any other thoughts about things that we aren't doing or could do here in Knox County that might help based on the recommendations in the report.
So, Dr. Buchanan, I'd like to just specifically read just the one statement about kind of those that are more vulnerable. And so it says, and this is specific for Tennessee, this report, it says, it must be made clear that if you are over 65 or have significant health conditions, you should not enter any indoor public spaces where anyone is unmasked due to the immediate risk to your health. You should have groceries and medications delivered. Now, I'm not saying that that's what everybody has to do. I mean, clearly we've not, made that a regulation, but that is how they stated. And I showed you the age demographic breakdown of our hospitalizations. So I think that those folks have to be particularly careful right now, because remember we said that we're in a situation where people don't necessarily know who it was they were around where they contracted COVID. And that's what makes me so concerned also about the post-Thanksgiving spike.
Thank you, Dr. Shamil. Any other things to go over this evening?
One other thing for me, sorry. Just to let everybody know, tonight is Narda's last Board of Health meeting. She is leaving Knox County Health Department. And so I just wanted to let you all know that, so you can let her know, kind of gotten to know the voice behind the roll call. So just to thank Narda for her service and thank her for serving the board and the way she's weathered us through this interesting time. So thank you, Narda.
Thank you, Narda.
Thank you.
Thanks, Narda.
Thank you.
Thank you, Narda.
You are so very welcome. Thank you for all you do for our community.
Any other things to go over this evening? If not,
I move we adjourn, sir.
so that sounds like a plan. A second, and we'll call it a day.
I'll second it.
Sounds great. Thank you, Dr. Drake. So our next meeting is in about 2 weeks, and we'll see everybody then, if not sooner. Thank you and good night.
Thank you.